Thank you very much. Thank you, Eva Kimi, for the invitation. And what to do? To show this. Okay, thank you. Next slide. What's that? Who's showing this? How define consolidation? It's a treatment within a given time, aiming to deepen the response achieved during prior treatment or treatments. Maintenance is a continuous treatment aiming to maintain the response achieved by prior treatment. And the goal of both is a longer PFS and overall survival. So, what to maintain with? There is an old study with interferon, as you know, showing 6 to 8 month difference in PFS. There are a lot of studies with cortisone showing difference in PFS. Thalidomide, we will be talking about later on. LAN, bortezomib, ixazomib. There are, at least where I know, 2 or 3 maintenance studies ongoing, both in younger and elderly patients, or combination of these drugs. So the old thalidomide maintenance trial, all of you have seen these. All of them show difference in PFS. Some show difference in overall survival. If you notice the Barloghi study, there is a huge difference in PFS, about 2 years. And the last one was withdrawn by the first author because he didn't trust the CRF work done by the local centers, including patients. So LEN. We have 3 major trials. The French one, Palombo trial, the most recent one, and the American McCarthy trial. All of them show benefit in PFS, and only one show benefit in overall survival. I won't go in details in these trials, but all of us have been seeing the results, and probably all of you have read them also. Instead, I chose to show you some patient cases that I have at my clinic. It's a woman born 68 and a man born 77. She had 2 kids, and he had 2 kids also. The youngest was 2 months. She's working as a journalist. He's a computer science. Smoldering myeloma, massive bone disease, aggressive myeloma. 13% plasma cells in bone marrow, and IgG 90 gram per liter. 30 partial remission after induction. The woman has an IgA myeloma. He had a translocation 414, and she had 414 and gain 1. She had a twin sister, and the man had 2 brothers, but no matches. So eventually the woman get treatment demanded by decreasing in hemoglobin. We chose to treat her with VCD 6 times. We did an autologous and then an allogeneic bone marrow transplantation. I gave her maintenance with lenalidomide 2 years. The male patient was treated in the same way, but with tandem autologous, because the M component was still, he was in very good partial remission after the first one. He was treated with full conditioning, allogenic transplantation, and maintained with 2 years with LEN, and in CR since 6 years ago. So the question is, have we cured these patients? I do believe so. This is a trial showing the increased depth of response with time treating with lenalidomide, done by the French group. It's important to remember that a patient treated with Lendex can can improve the response rates even 1 year after starting treatment. And I have the pleasure to run my own trial in the Nordic country. It's a trial with Lendex in second line in naive patient. On response, the patient were randomized to continue with Lendex or just to get Len as maintenance during 2 years' times. So I won't show any results from this trial, but I will show you some patient cases, hoping that we will conclude together how to do with maintenance treatment. The first patient, a male patient, came with IgG myeloma, was treated as usual at my center with VCD and high-dose treatment. Shortly after treatment, he was relapsed, 3 to 4 months. He started with the trial that I mentioned. The first part was until response, at least partial remission, then randomization. And the patient had the possibility to refuse to stand on maintenance with Len. In that case, we gave them 9-month treatment with Len. The patient did refuse to be randomized, so he only get 9-month treatment and start to have a chemical progress during time, but it took 3 years for him to be treatment demanding. And in relapse, he did receive Lendex again and responded. This is a partial remission patient. He didn't achieve more than partial remission. Another one, woman born 35. We give VCD to all patients, by the way, both young and older. She achieved partial remission, but progressed in a short time, included in both part of study, with total treatment of 30 months. As soon as we stopped the drug, she started to progress. And she had only achieved partial remission on treatment with Lendex. Third case, male born 53, VCD and high-dose treatment, did not respond to high-dose treatment. As you see, the M component is at the same level, eventually progressed, was treated with Lendex, both part 1 and 2, and total treatment of 30 months, and partial remission, and progressed as soon as we stopped the drug. So, these are typical patients in the whole trial, achieving only partial remission and discontinuing maintenance will result in momentarily progress. It's a female born 37, treated with VCD, was included in both parts. As you heard earlier, cataract operation is becoming more and more usual. She is 3 years on treatment. It's a protocol violation. She only received VGPR. She refused to discontinue treatment, and I agree with her. A man born 42, VCD, good response, but severe neuropathy, and you don't see it, but there is a hack in the M component. He did actually progress. Received both part 1 and 2, end of treatment on 28 months, CR. As a result, I'm showing the total immunoglobulin amount, not the M component, not the M protein, and 1 year from discontinuation, still on CR. Another case, male born 44, VCD and high-dose treatment, relapse, VCD and high-dose treatment, but only in few months relapse again. and was included in the study, achieved CR, and had CR on discontinuation also. VCD, high-dose treatment, the study, end of study, CR, and CR 1 year later from ending the treatment. This is not a study patient, but a patient that has started on Lendex to start with in first line. Very wonderful response, CR in about 3 years. She got squamous skin cancer and was operated in the face 3 times. We discontinued the treatment, or the study. It was a treatment, not a study. And later on, she also developed a neuroepithelial tumor. So two cancers, probably secondary to treatment. So is LAN the optimal maintenance drug? This is a patient that I had, lot of treatment, get everything. High-dose treatment, VMP, MPT, Cyclo, Veldex, PAD, Landex, and only achieves PR, as you see, was put on daratumumab, and he achieved CR. Another patient, born 58, induction was VCD without any response, VRD without any response, and eventually we decided to give him a high-dose treatment after 6 cycles with VCD and 3 cycles with VRD, and he didn't respond to high-dose treatment either. And he is on daratumumab since 20 months now, and in partial remission. So, some conclusion, if I may say them with you, I hope. Almost every active myeloma drug can be used to maintain patient with. We know that with cortisone, we know that with interferon, but we never use interferon today because of the side effect. We never use cortisone because of side effects. Probably less and less people are using thalidomide to maintain with because of side effects. The optimal maintenance drug should be oral administration. And one should consider both consolidation maintenance treatment patient not achieving CR, especially in younger patients. If you choose to maintain patient, you should most probably not discontinue this treatment if the patient already achieving PR or VGPR. But one might consider to discontinue if you have a very good response, as in CR. Or stringent CR. Thank you very much.
Thank you, Dr. Nahi, for the nice presentation.